I have the pleasure of introducing Dr. Tim Buchman, standing here with me. Dr. Buchman, you may know, but certainly for those who don't, he's a professor of surgery, anesthesia, and biomedical informatics here at Emory. Was also the founding director of our Emory Critical Care Center, but perhaps he's more well known for all of his international, global, and intellectual activities, including his role now as the senior advisor for the DRIVE initiative at PARTO in the Department of Health and Human Services for our federal government, but also as the fact that he is a past president for the Society of Critical Care Medicine as well as the Society for Complex Acute Illness. And also he's the editor-in-chief for a couple of the journals that we think about a lot. The older one, Critical Care Medicine, but the newer one, which you may or may not even know about yet, Critical Care Explorations, which is a new journal specifically from the Society of Critical Care Medicine. So Tim this morning is going to talk to us about burnout, whether it's inevitable and both within the ICU and also more broadly. So Tim, thank you very much.
Greg, thanks so much. I appreciate it. Good morning, everyone. This is not the talk that Greg thought I was going to give. He asked me several months ago to come talk about burnout, and as I started looking into it and asking what would be valuable to you, this is what came out. Now, before I get started, a couple of disclaimers. Yes, I'm editor-in-chief of the journals. Nothing I say today is supported by or endorsed by the journals of the Society. Yes, I now work part-time for the United States government. Nothing I say this morning should be taken as a position of the United States government. Yes, I'm a faculty member here at Emory University. Nothing I say today should be taken as an official position of Emory University. This is Tim speaking with each of you. So far in this summit, it's been about the patients. This talk is all about you. I have no disclosures for this presentation. I get neither travel nor lodging costs. I live about 500 meters from where we're meeting. I do lecture all over the world on a variety of topics in my roles as editor-in-chief of the journal and so forth. Typically, travel and lodging are paid by the hosts. I've listed some recent hosts. But from my standpoint, none of this represents or should be seen as a conflict of interest. Now, my remarks today are going to distress a number of people. They may distress all of you. So the trigger warning is right here. You're going to have explicit content because I'm not going to use rhetoric. I'm going to use science and facts to take you through some logic. Okay? So if you're sensitive to, actual information, this would be a good time to step aside. Okay, let's get started. This is sort of the talk map. We agree on the definitions of some words. We're going to talk about where we are and how we got here. Talk a little bit about what we might do about it. And then in the breakout sessions, we're going to delve more deeply into what the future holds. But for now, let's get started on meetings. Everybody clear on what the definition of is? 20 years ago, that was an issue during the Monica Lewinsky, Bill Clinton things. I'm not going to fight you on the definition of is. Is conveys some sort of characteristic equivalence. The sky is blue. The patient is unstable. The speaker is crazy. One of these sorts of things. Let's just get past the is. What about inevitable? Inevitable means it is going to happen. Okay? Not a matter of choice. If we decide burnout is inevitable, I'm going to tell you it's going to happen to each and every one of you at some point. I've got those two things out of the way. Let's start in on the hard one, and that's burnout. Most of you have an idea in your mind of what burnout is, and I will tell you without asking you to exchange notes with your neighbors that no two of you are thinking the same thing. The first reference I could find to burnout wasn't in the literature as you and I think of it, it's from fiction. Graham Greene, a famous novelist, wrote a novel published in 1960, 59 years ago, entitled A Burnout Case. wasn't writing about a medical professional. Writing about an architect by the name of Query, very famous guy who got tired of being the celebrity and tried to go somewhere and hide out because he no longer found meaning in art or pleasure in life. Well, it was the title of a novel. But within a few years, Herbert Berger, who is a psychologist, and I believe they did some additional work in sociology, coined the term burnout, or at least claimed to coin it. The OED credits him with first using the word burnout in his 1974 book, Burnout, The High Cost of Achievement. And he defined burnout as the extinction of motivation or incentive, especially when one's devotion to a cause or a relationship failed to produce the desired result. In fact, this is the front piece of the book that he wrote with Geraldine Richardson. This is the 1980, this was, a few editions downrange. But interestingly, this book was reviewed in the Journal of the American Medical Association in 1981. Now, you can't read the words here, but I'm going to give you a little bit of the abstract. What is burnout? You can get a lot of opinions, including the view, perhaps a semantic argument in some instances, that there's no such thing. In the terms of this book, it is often a condition which likely to succeed persons begin exhibiting signs of something amiss between themselves and their environment. Clinical psychologist Berger says he has experienced it himself, that what is happening is not just something inside the person's affected. No, suggest the authors, much had to be attributed to the times we live in, the swift acceleration of change, the depersonalization of neighborhoods and schools and work situations. And then finally, in any case, whatever burnout is or is not, 1981, it is a much discussed subject these days, and physicians may want to examine as many viewpoints as possible. It's 1981. What else happened around that time? Christina Maslach and Susan Jackson published a paper, again, 1981, The Measurement of Experienced Burnout. Underlined in red, she cited the work of Berger and says that our initial research in this area was very exploratory. Now, she didn't tell us what that meant for another 40 years. Because in an interview she did last year for ACEP News, she told us the following. I had never heard about burnout. I described some concepts that appear in sociology, psychology, health literature, and the people she was interviewing said, no. And then she said, what about burnout? Yeah, that's it, oh my gosh. What I was finding it was really not a psychological concept, but something that was a grassroots sort of thing. And the people themselves said the term captured what they were feeling, and that's how she got started. Now, as you all know, burnout is not just a concept, it's an industry. Okay? This is mindgarden.com. You go to it if you choose on your devices. They give you this message, and there's a little figure down there over there in the corner with the little dots on it. I'm going to enlarge that for you. Because now you can be engaged, ineffective, overextended, disengaged, or fully burned out. And I don't know what it means when the little yellow thing in the lower right turns red. It's got to be something worse than burnout. Okay? But this sort of description is now throughout. You've got one of these for health, one of these for business, one of these for law. I mean, it really has become a thing unto itself. Okay. Well, we're number one. This was the 2018 Medscape survey. I got news for you. In 2019, we're no longer number one. It's urology that's number one. Urology? Okay. But in 2018, we're number one. This is one that you don't want to win. Well, we know it. And in fact, people who care about us also know it. On the left, from the Blue Ridge Group, headed by our own Dr. John Lewin, the hidden epidemic, the moral imperative for academic health centers to address health professionals' well-being, and the quad societies, the 4 societies that are involved in critical care in the nation, came together and said our official critical care society's collaborative statement, Burnout Syndrome and Critical Care Health Professionals, a call to action. It would help if we really were clear about what it is we're acting on. So if you're Renzo Bianchi, every time a Burnout article is published anywhere in the world, he writes a letter or a new article. He says, you know, there's a very tight linkage between garden variety depression and some other neuroses. Renzo Bianchi, feel free to look him up. I don't want to spend a lot of time with this. But he said, you know, maybe we ought to look at some of the psychiatric underpinnings of me and you and you. No, we're not going to do that. We don't want to hear that because that would be victim shaming. How many of you know Dr. Z? Okay? You should go to his website, Zubindomania, ZDog MD. He basically is a hospitalist. He finished his medical school about 20 years ago. As a side gig to combat burnout, he does stand-up comedy. He has his own sort of stuff on the web. It's very interesting. He has a video. All you have to do is go to ZDog and moral injury, and you'll get this. I've just done screen grabs for this. He says, burnout's a type of victim shaming. So it's not burnout. We're not suffering from burnout. It's moral injury. How many people have seen something about burnout and moral injury in the past month or two? Yeah, a number of hands gone up. Anybody know where that came from? It came from an article in Stat News published by Simon Talbot, who is a plastic and reconstructive surgeon who works up at the Brigham, and Wendy Dean, who used to be with the government. She's now at the Henry M. Jackson Foundation. And they said, physicians aren't burning out. This could be applied to nurses, respiratory therapists, anybody in medicine. They're suffering from moral injury. And what did they say? The moral injury of healthcare is not the offense of killing another human being. They took this concept from war. It's being unable to provide high-quality care and healing in the context of healthcare. If you go on to read the article, basically what they say is we're all in the Gumby model of healthcare. We're stretched in so many different directions, serving so many different individuals, that we can't actually get back to the job we thought we were doing when we chose a health profession in the first place. We believe that burnout is itself a symptom of something larger, our broken healthcare system. The increasingly complex web of providers' highly conflicted allegiances to patients, to self, and to employers, and its attendant moral injury may be driving the healthcare ecosystem to a tipping point, causing the loss of resilience. Now, what just happened here? Okay? Depression or neurosis, or you're not strong enough. That's the I'm not good enough tape playing inside, right? So you should be ashamed of yourself, buck up, you can do better. What they've just done is said, it's not you, it's the world around you that's causing it. We're shifting from shame to rage. You're angry now that you're burnt out. As well, you probably should be. No, it's not moral injury. If you talk to Pam Weibull, who's a physician who is probably the world's expert on physician suicide, okay, she's taken this up as her own cause. She will tell you what you're experiencing are human rights violations. Human rights violations. And here's what she has to say. With no evidence-based treatments for physician moral injury and zero progress after 40 years of burnout prevention, what next? Enter the real diagnosis. Human rights violations with clear evidence-based solutions. Well, before we go on, can we agree on a few things? Starting in the 1970s, there's been increasing awareness that something has happened to workers' experiences. Now, while discussed among ourselves in the context of healthcare, it didn't start with healthcare, it didn't stay in healthcare, it's prevalent in other industries as well. But we tie the intensity of our experience as healthcare providers to the fact that we're different in that we care for our fellow human beings, not just about them. It's one thing to lose an account or fail at the Shark Tank competition. It's another thing to lose a patient's life. That's what sets us apart in the healthcare world. So let's recap for a moment. Query, the architect, anhedonia, Freudenberger, fatigue, frazzled and unfulfilled, Maslach, emotional exhaustion, depersonalization, a diminished sense of personal accomplishment, Renzo, depression and neuroses, but now we've got moral injury and human rights violations. I told you it's outer directed. It's coming from outside. And thus, if it's coming from outside, we got to find a villain, or at least a scapegoat. Yeah, candidates in mind? Me? So, just for the record, in contemporary mythology, we love to have technology as our favorite choice. You got the Borg, you've got the Terminators, you've got the Matrix, you've got your Death Star, and the reason you love it is because we always seem to get a messianic hero or heroine to save us from the machines. You got Jean-Luc, John Connor, Neo, you got your young Luke and Princess Leia, you got your old Luke and Princess Leia. We kind of love this business. Now, up until now, sci-fi health tech was never villainous. Okay, DeForest Kelley, who knows where he was born? Toccoa, Georgia, who knows where he went to high school? Decatur High School, he's native son, okay? I'm a doctor, not an escalator repairman, right? Couple of versions of Star Trek later, we got the emergency medical hologram and the holographic doctor, AI enabled. Just like us, kind of human. Would you want a holographic doctor? We're getting them, okay? Telepresence via holographic doctor is already prototype. We're going back to the house call. This company, Silver Chain, okay? This nurse is wearing glasses so she can see all the stuff on the wall. That doctor with the stethoscope actually isn't in the room. He's projected on the glass. I don't know how he's going to use the stethoscope through the hologram, but at least tells you he's a doctor and he's got the Mr. Rogers sweater on, right? That really is a Microsoft HoloLens 2, it's version 2, and they're doing this stuff now. Now, it's not widespread, this is being tested out in Australia, but it's there. We gotta have the villain, right? Enter the villain, up music, the electronic health record. Okay? This is an article from Forbes, ran at end of March, okay, about a month ago. Death by 1,000 clicks, where electronic health records went wrong, and right up there, because it's Forbes, it's the US government conspiring with the EHR to make life miserable. An epidemic of burnout, okay? So it's all based on a Harvard study. One of the co-authors of the Harvard study pinned much of the blame on the growth in poorly designed digital health records that have required that physicians and nurses and respiratory therapists and whoever spend more and more time on tasks that don't directly benefit patients. And in fact, if you go back and read the source article on which this is based, you can't read this, but I'll tell you, how did we get here? They talk about the electronic health records starting in the 6th line, okay? And then they start talking about improving EHR standards with strong focus on usability and EHRs. Okay, so we got us a villain. In fact, Dr. Z says so. And then we meet an electronic health record that is a glorified cash register with a little patient stuff tacked on. You change the electronic health record to make it about bringing us closer to our patients. Man, that's powerful rhetoric. How are hospitals actually using the electronic health record? This is from healthit.gov. It was issued 2 days ago. Hospitals commonly use their EHR data to support quality improvement. That's 82% of the hospitals. Monitor patient safety, 81%. Measure organization performance, 77%. The gold is 2015, light blue is 2016, dark blue is 2017. Now, let's all agree that if you don't document it, it's not done. If it's not done, it doesn't get billed. And I don't know any business that doesn't connect what they do with some kind of, billing tool. I mean, that's just part of it. But it's not a glorified cash register. So the current contemporary narrative is fix the electronic health records, everything will be wonderful. Right? Meetings about it, reports in it, and so forth. We got us an scapegoat. But if you've been following what I've been saying, there's a little problem. In blue, that's the annual citation count, not the cumulative. That's the number of papers published each year starting in 1977 with Burnout. The red line over here, it's percentages over there on the right. That's the percentage of hospitals that had even basic EHR. We're not talking Cerner or Epic here. We're talking, can I get the lab values on a computer? So what you've got to do is reconcile this narrative, it's the government and the EHR, with the fact that the burnout stuff started way back here. How are you going to deal with that? Something doesn't quite fit. All right. Now, I got to put on the glasses. Queued up the glasses. Now, Laurence Fishburne was also born in Georgia in Augusta, 1961. I can't do the voice. Let me tell you why you're here. You're here because you know something. What you know, you can't quite explain, but you feel it. You felt it your entire healthcare working life. That there's something wrong with the healthcare system. You don't know what it is, but it's there. It is this feeling that has brought you today. Do you know what I'm talking about? This is your last chance. After this, there is no turning back. You take the blue pill, the talk changes. You wake up tomorrow and recall you heard a talk on, is burnout manageable? You'll recall mention of lavender essential oil, massage, yoga classes, mindfulness training, all coordinated by the chief wellness officer. You take the red pill, we stay on topic, and I show you how deep the rabbit hole goes. title of this talk is Burnout Inevitable? All I'm offering is the truth, nothing more. So it's your choice. We can do the blue pill talk. We can talk about all the management stuff. But that wasn't the talk I set out to give. So if anybody wants the blue pill talk, this would be a good time to leave, because what I'm about to tell you, you can't unhear. What I'm about to show you, you can't unsee. So much for the problem. I grew up listening to Barbra Streisand. Okay? People. She seems to have only one quote on the internet. Progress, whatever your definition of it, is not inevitable. And contrast that with Harry Greenspun. Harry was a junior guy with me at Hopkins, anesthesiologist, spent a bunch of time at Deloitte, chief medical officer for Korn Ferry, now runs Guidehouse. And Harry says the future of healthcare is the present day of every other industry. Now, there are probably other positions, but those are the polar opposite. So now we have to get to what's happening and why. Dr. Z again. This is the beginning of the moral injury tape. I'm really tired of people calling it burnout. It's exhaustion, low productivity, and a feeling of deep cynicism. Low productivity? Who here feels like they're unproductive? Not too many people in the room, maybe one or two hands. You actually think that that's a fair statement? Let's talk about this piece from the New York Times. It was entitled "Tech is Splitting the U.S. Workforce in Two." But when you look at healthcare and social assistance, they say, yeah, it is a low productivity job. And in fact, if you plot the different jobs, down here you've got the axis, less productive and more productive, and you can see increased share of jobs, decreased share of jobs, more healthcare jobs, but people saying low productivity. Better read the article a little bit. The first thing they've said, in the last 40 years, jobs have fallen in every single industry that introduced technologies to enhance productivity, so that scares a lot of people. And then there's a piece that says, well, many jobs are being automated. There are still holdouts in the economy, especially in the health fields. And then they get an expert from Banner who says there are not huge opportunities to increase productivity, but technology has a significant impact on quality. So there you have a clear statement from the COO of Banner: we cannot increase productivity in healthcare. Of course, there are opposing views. One of the opposing views comes from this guy. His name is Franz von Gluten. He is the CEO of Philips. You may not realize it, but about 5 or 6 years ago, Philips stopped making light bulbs and electric razors. They are now a pure healthcare play. He employs 120,000 people worldwide. If you search on future of healthcare in 5 words, and you don't have to get that, I'm just telling you where it's from, you'll find a 30-minute lecture. It's on the Washington Post site. It's worth listening to as much as Z-Dog is worth listening to. And he says there are 5 things that are going to drive healthcare in our future. Outcomes. We're not going to, you have to measure and get better. Inclusion, meaning access to health care. Innovation, sure. Seamless, meaning you don't want to have to repeat your medical history every time you go from one office to the next. But right in the middle is productivity. And he is sold on the idea that we have to become more productive, not a matter of choice. Now, if you ask the American people, we only want workforce automation being limited to dangerous and dirty jobs. So this is a Pew Research thing published a couple of years ago, and people either strongly favor 47% or favor 38%, the combination, you can do the math, 85%. They want to limit machines to doing dangerous or unhealthy jobs. Okay? In the meantime, Japan is already generating robot carers. This is not sort of hypothetical. These things are being deployed in nursing homes throughout Japan. Why? Because Japan is full of old people and there are no young people to do the job. This is a pragmatic solution to, we don't have enough people to do the work. But it gets to the question, why are we hemorrhaging people? This is emergency nurses. But I could have written any profession, any sector in healthcare up here. This is the common experience. You never have a moment to breathe. You just keep trucking to the next. The institution as a whole does not value any employee as an individual. Rather, you simply are a number and someone else will come along. Like it or not, this is emergency nursing today. They are burned out. They feel overworked, undervalued, abused, unappreciated, and not supported. I'm not going to ask you to raise your hand. I'll tell you that every one of you in this room has had that sensation at some level, sometime in the recent past. It's okay. This is what we're all experiencing. Now, it's pretty clear that a company that has a shaming, judgmental culture is not going to generate wonderful customer service, and it's equally clear that there's an appropriate and relentless focus on customer service and healthcare. Every time you touch a patient, there's a Press Ganey thing that comes out. Okay. So we got to get rid of the shaming, we got to get rid of the judgment. And in order to do that, we have to understand why. Why we are all in this environment, why we're all feeling the same things. I put up covers of a couple of books. If you've got nothing better to do, read them. Okay? I'm going to pull a couple of ideas from these books, but understand I'm only scratching the surface. But I think they may help you understand why you feel as you do, and I'm going to hit a few of the high points. Next frame I'm going to show you is about America as a whole. It's not about healthcare, but it is about the country, the nation we live in. Right around 1973, at the end of the Vietnam War, in constant dollars, wages became stagnant and productivity skyrocketed. Basically, when some of the automation started. Now, this is not the personal computer. Personal computer didn't show up for another 12 years. Okay? But this is people coming back from wartime and figuring out what needed to be done. How is that accomplished? Well, if you go back about 20 years, there were 10 airlines. Today, there are exactly 4. You go back about 20 years, there were 37 banks. Today, there are exactly 4. Now, you guys are from a bunch of different healthcare systems. I intentionally left this one blank. But if you're from Emery or Piedmont or Wellstar or Kaiser, you might think about what the recent history has been in your healthcare system. And I can tell you to a degree of certainty, you're going to tell me about mergers and acquisitions. That we keep agglomerating into these larger and larger entities. Now, it's slowed because basically the healthcare world has kind of run out of things to merge. And what you see is what we're likely to get for a little while. It's not just big hospitals. Okay? How many drugstores are there in the United States? Anybody? I mean, companies that run drugstores. It's about 4. Okay? These are major metropolitan areas, and who covers them? Walgreens in purple, CVS in blue, Walmart in green, and Rite Aid in orange. Yeah, there are a few independents left out there, but basically there are only 4 places that you go get drugs. talk a little bit about what people are labeling today as integration. How many Emory people do we have in the room? A bunch of Emory people. How many people get their health care from on the job from Emory benefits? Fair number, right? So you have Emory and your benefits, and to a degree of certainty, if you're getting it through Emory, you're getting Aetna, right? Everybody got Aetna? Right. Okay. Because that's your choice, Aetna A or Aetna B. Okay. Now, Emory is represented down here, but it could be Penn, Stanford, or any other major universities and systems. But it's not just universities and systems. United Nations will give you Aetna. Big companies like Dow will give you Aetna. Okay? Department of Defense will give you Aetna. Okay? Why am I showing you this? You see here, it says Aetna. See there, it says Aetna. You see the difference between the two Aetnas? It's that little heart thing, right? You seen that little heart thing before? Yeah, sure you have. You see it here. And the reason is a year ago, CVS purchased Aetna. Okay? Let me make sure you understand what I just said. CVS owns Aetna, which controls your insurance. CVS also owns Caremark. Anybody know what Caremark is? It's called a pharmacy benefits manager. Okay? So not only do they own the insurance plan, they own the people who decide what's in Tier 1, Tier 2, Tier 3 drugs, right? But suppose you're not feeling well. What are you going to do? You can go to a Minute Clinic, right? Now, Piedmont people are saying, oh, that's not us. Walgreens. These are the integration alignments that are going on. This is what's happening around you. CVS, what does that stand for? In the 1990s, the CEO of CVS said he now considers CVS to stand for convenience, value, and service. And of course, that's not how it got started, is it? Okay? Consumer value stores, basically the Dollar General of the day. That is who's controlling your health care. Now I don't want to pick on CVS. We could pick on them because of the Aetna deal, but Walgreens is eating Rite Aid. Cigna has purchased a pharmacy benefit manager called Express Scripts. What have I told you so far? First, that burnout is incompletely defined. You can do the Potter-Stewart thing, right? You know, I can't define it, but I know it when I see it. I've told you there's substantial consolidation of the businesses of healthcare, and like Ethel and Lucy with the candy moving down the line, you know, they can't keep up. You feeling like this at the moment? Any of these things? Lost, confused, unsure, perplexed, disoriented? I know I am. What are you going to do about this? Well, the first thing is, I know what everybody's telling you at the moment, become resilient, right? Okay? And they're actually right. We do have to do something with ourselves, okay, to make ourselves strong in the face of this. In building these strategies of optimism, self-belief, control of self, willingness to adapt, willingness to be flexible, and so forth, that actually does matter. It's a management strategy. It's not a fixed strategy, but it's a management. And just so we're clear, it's also an industry. You got the Resilience Institute, the Atlanta Office of Resilience, Health Affairs tells us that there's a unique role for the Chief Wellness Officer. It's important. Why? Because the health and well-being of healthcare providers matters. That's you and me. Remember, we started with the triple aim, the IHI triple aim of population health, experience of care, and per capita cost. That means better outcomes, better experience of care, greater value. And a couple of years ago, two people, Thomas Bodenheimer and Christine Sinsky, wrote a little paper in the Family Medicine Journal saying, from triple to quadruple aim, care of the patient requires care of the provider. Sinsky now works as the wellness officer for the American Medical Association. But they said, well, there's a fourth aim. So they said, what's the fourth aim? Well, if you look at this group of the fourth aim, it says it's productivity. This one says it's physician alignment. And this one says IHI has a quadruple aim. Go to the IHI website. They've never embraced that quadruple aim. They're still back at the triple aim. Don't believe me, just look. Now, for the record, and to be absolutely crystal clear, Emory is on the record that the quadruple aim of better patient health, better patient experience, lower relative costs for patients and families, and greater joy of providing care for staff and physicians, that's what Emory is about. And that's why I'm proud to be an Emory faculty member, because they went on the record and said, yeah, we're actually believing in this, and we're going to do something about it. Understanding that some of you work for different healthcare organizations, let's simply embrace provider well-being and wellness is essential to the health of the organization, whether you or not you designate it as a fourth aim. Why is this so hard? Now we got to talk about leadership, and this is where it gets dicey. I'm going to invest some time attending to your fears and feelings, because if I don't, or I squander an unreasonable amount of time trying to manage ineffective or unproductive behavior, it doesn't work. And we got to talk about some hard things. This is the hard thing. Competition in healthcare is real, and survival of any given institution or system depends on productivity. Every other system of every other industry I know about has had to deal with this, and the world is littered with problems. Kodak said, you know, we have the patent on digital photography, but no, we're just going to keep giving people film. They had the patent on it. Kodak is basically shattered. Down at the bottom, GM. Nobody wants a cruise anymore. They want an SUV. Increase productivity and please the customer, or wave goodbye. Now, who here has heard of hospital closures? Yeah, we've all heard of hospital closures. 911, Lower Manhattan, Twin Towers went down. 2001. Where did people go to? They went to the hospital that had been anchored at the bottom of Manhattan for 100 years. St. Vincent's Hospital. Okay? 10 years later, it was declining. 2 years after that, it closed. One hospital in Lower Manhattan. Who here knew John Puskas when he was here? Okay, got a bunch of hands. John Puskas, outstanding cardiac surgeon, was recruited away from Emory, become the cardiac surgeon at this hospital, Mount Sinai Beth Israel. 3 years after he was recruited there, it closed. The second hospital in Lower Manhattan. This is not a critical access hospital somewhere in rural Georgia. Anybody here from Philadelphia? You heard of Hahnemann, right? Yeah. Hahnemann is in its death throes. Tenet, the for-profit company, bought it, couldn't make it profitable. They sold it to a turnaround artist in California who spent the last 2 years trying to make it profitable. 3 weeks ago, they laid off 200 people. If this thing closes, it's 2,500 jobs. In the middle of Philadelphia's center city. What's the market saying about CVS? Just so you know, the red line there is the Dow Jones, the blue line is CVS. It was high flying a couple of years ago, it's now dipped below the Dow. So CVS is going to try to figure out how to make us all profitable. This is the hard thing. Healthcare is an industry that competes for covered lives and must produce care. Doesn't matter if you're with Emory or Piedmont or you're from out of town, you're playing a role in this competition. You are in this productivity movie, and you don't get to get out of it. So now the question becomes, what strategies win for each of you, and also for your own boy? Anybody know this picture? Who knows this picture? Anybody in the room? Just, you don't have to tell me what it is, just raise your hand. This is a picture, we got one in the back, okay? This is a picture I want you to remember. The guy in the middle there with the top hat, that's Teddy Roosevelt. The folks in the other funny looking hat, they're French. Because this photo was taken April 23rd, 1910, 109 years ago at the Sorbonne in Paris. Roosevelt gave a speech entitled Citizenship in a Republic. France was not doing well. I mean, this had nothing to do with Notre Dame burning, but they had huge environmental problems. The economy was tanking. I mean, there were all sorts of things going wrong. And he gave a very long speech, most of which is forgettable, except for one paragraph. And that one paragraph, in my opinion, probably should be part of the American canon at the same level that the Gettysburg Address should be part of the canon. It's called Man in the Arena. Cadillac used it as an ad about 2 years ago. But you gotta do this. You have to stay engaged. Your engagement matters. You're essential to healthcare. You know what is essential to patient care. And what Roosevelt said, it's not the critic who counts, not the man who points out how the strong man stumbles or where the doer of deeds could have done him better. The credit belongs to the person who's actually in the arena, whose face is marked by dust and sweat and blood, who strives valiantly, who errs, who comes up short again and again, because there is no effort without error and shortcoming, but who does actually strive to do the deeds, who knows great enthusiasms, the great devotions, who spends himself in a worthy cause, who at the best knows in the end the triumph of high achievement, and who at the worst, he fails, at least fails while daring greatly, so that his place will never be with the cold and timid souls who neither know victory nor defeat. If that's too much to remember, then take the modern version. Okay, Lin-Manuel Miranda is Hamilton. I'm not throwing away my shot. You are part of the solution. Now, Emory, if you're lucky enough to work for Emory, you have your shot. There's a new program called Empower. I've given you the website here if you want to look at it. Indeed, here at Emory Healthcare, we have outstanding people doing the most top-notch work possible within a process that needs improvement. And that's why they've used the Cox Foundation grant to launch Empower, a new way of doing business that will flip the script by empowering frontline healthcare workers to solve problems and improve processes in order to enhance patient experiences outcomes, as well as their own professional joy. As Bill Bornstein put it, the moment we get good results from great people using broken processes, we're going to get spectacular results from brilliant people using great processes. But it's going to come grassroots, bottom up. Second strategy. Anybody know what that thing is on the upper left? It's a vending machine for cars. Okay? It's a car vending machine. You don't have to go deal with, negotiation with dealers. They tell you what the price is, you feed the money in, it spits out a car. When I started flying on the airlines, I had to go to a travel agent, get a ticket issued, and then, you went to a ticket taker and they tag your bag, all that kind of stuff. We don't do that anymore. We take responsibility for it. Why? Because both of those things save us time. Even Amazon figured out that it might be more valuable, instead of you waiting at home for the package, to put it in a locker. Incidentally, instead of making 75 deliveries, they make one. Anybody use the Amazon lockers yet? Yeah, it's nice when you've got something valuable coming so you're not wondering whether it's going to be taken from the porch. Okay. You give the customer, and the customer may be you or it may be the patient, family choice and control, let them manage their time, helps everybody. Why do we know time is important? Go most places in the country, they'll tell you how long you're going to wait to see a physician or a caregiver. And wait time information, the Minute Clinic. One of the things we did with the Emory Critical Care Center is we said to our folks who were working all night and feeling lousy the next day, we said, let's turn night into day. We'll take you down to Australia, let you do your night work remotely in the daytime. And people smile and they're happy about it because I've given them back valuable time. That's productivity for you. Not necessarily seeing more patients. It's helping people make the best use of their time. You want to manage your time. Now, I've seen it from the other side. Many of you know that I was hospitalized 2 months ago with sepsis. Yeah, I met sepsis 3 criteria. Me, last dose of antibiotics. I had 3 major irritations during this stay. It was a great stay, don't get me wrong. 5 stars, press Gainey, and all the boxes. I had 3 major irritations. The first was, how many people here have actually ordered a meal at the university hospital, right? They give you a paper menu, you dial a number, meh, 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 okay? The 20-minute wait time on the telephone to tell somebody what I wanted. Then with all that fluid, I wanted to get up and pee. You know how much fun it is being tethered to that thing? Okay, not fun at all. And finally, there's nothing better than getting up at 5 a.m. so somebody can jab you with the heparin needle. Okay? It's exactly how you want to manage your sleep time. Well, let's change that into an innovation list. What if, in Emory, we did what we do at Chili's, right? You go into Chili's and you push the button and the food appears. It's not exactly high tech. Could we do that? How much time would we save, both patient time and here's your menu and what would you like, What if we figured out how to marry a camelback to a pump, and instead of having the thing on the pole, we actually gave it to the patient to wear? That couldn't be done. So a liter of fluid, so we're clear, a liter of fluid, take a 10-inch square, 10-inch square, make it 5/8 of an inch thick, that's a liter of fluid. Pump there. You can plug it in when you're not using it, but when it's time, just walk around. Actually get the patients to ambulate. That might actually help a bunch of people. And now enoxaparin is generic. I mean, can we actually make the switch so I don't have to be woken up at 5 a.m.? And in fact, that reduces the 3 injections to 1. Time matters. My point about this is you can do it from the front lines. You can see where the opportunities are. So the no regret strategy number 3 is to innovate locally and then grow it globally. You know your environment, the challenges and needs better than anyone else. So the challenge I'm going to give you as you go home for the holiday weekend is to ask, what can you do in your immediate environment to create meaningful time? Now, I left this thing intentionally blank because I actually want you to think about it. Maybe not right now, but start asking yourself, what can you and your team in your work environment do to create meaningful time? Because time is the one currency that we all share. I don't care whether you're a doctor, a nurse, patient, family member, you're a supplier, you're an administrative person, time is the one thing that we all have in common. So, is burnout inevitable? Yeah, here's why. Our professions are changing, our work environments are changing. What is expected of us tomorrow is different than what we do today and quite different from what we signed up for yesterday. And underlying all of this is a relentless quest for productivity. I'm sorry to tell you this, that's not going to go away. So the dissonances inevitably lead to feeling overworked, undervalued, abused, and unappreciated unless and until you decide to lead change and not be led by it. Let me leave you with two thoughts. On the left, Morpheus. Believe me when I say we have a difficult time ahead of us, but if we are to be prepared for it, we must first shed our fear of it. And finally, I'm not even going to try to pronounce Eric's last name, the future isn't preordained by machines. It's created by humans. Thank you.